All right, let's wait for a few minutes for your other classmates to get in. All right, I just placed in the chat your attendance for today, so please fill it in. If there's any problem, please let me know. Okay, everyone, I'll start at 4:05. So everybody can see my screen with the cursor.
Yes, yes, doc.
Okay, that's good.
Yes,
All right,
Doc.
so we'll start in a few minutes. So if you have to go to the comfort room, get a cup of coffee, now's the perfect time to do it. All right, it's 4:05, so let's start. Okay. All right, good afternoon, everybody. Welcome to our second lecture. Well, first lecture, technically. All right, so last confirmation, everybody can see the screen. Yes, because all of your exam questions are coming from the slides.
Yes, the
Okay, perfect. My voice loud and clear. Sorry, I'm not as familiar with Google Meets as I am with Zoom. Voice is okay?
yes, the
Okay, good. Sige go. All right, let's start. So, everybody, welcome again. Today, we will tackle the basics of radiology as well as radiation safety. So, the outline for this afternoon would be, as the title implies, basics of radiation as well as radiation safety with different imaging modalities. So, while we are in the topic of radiology, it is very important to know the very basics of radiation, including its effects and, most importantly, its safety. So, why is this so important? Because the interaction of high energy X rays with the atoms in our DNA and other molecules in the body will eventually have biologic effects. But we must not fear it, rather, we have to respect it. Remember that most diagnostic exams will expose our patients to a relatively low dose. It is nice to note that in our country, we are required by law to monitor these doses, and these, based on studies, are relatively safe. But how do we reassure ourselves that it is safe? So we have to live by the ALARA principle, as low as reasonably achievable. So, what does that mean? This principle means that no matter how small or seemingly harmless the dose is, if your patient will be receiving that dose with no direct benefit, then as much as possible, we must avoid it. But how do we follow this? How do we protect ourselves as well as our patient? You have to remember three things: time, distance, and shielding. In order to have the lowest dose, we have to minimize our time near a radioactive source, only to what it takes to get the job done. There is no reason to spend more time around it than it is necessary. Distance refers to how close you are to a radioactive source. So, for example, in an X-ray machine, it is where the X-rays are being emanated. So you have to make sure that you have to maximize your distance from this source as much as you can. This is the easiest way to protect yourself because distance and dose are inversely related, meaning the farther you are from the X-ray or the radio emitting device, then therefore you would decrease your dose. Lastly, is shielding. It is important to shield yourself from a radiation source. So if you notice, if you've been to the emergency room or in radiology or even in the OR at times, you would see that the X-ray techs or the our friendly rad techs would be wearing a lead gown. It may be accompanied with a thyroid shield. Back in the day, there used to be a gonadal shield for men. However, now that the apron is already more than enough, and then also you have the goggles. So all of these things are all shielding. This is also one of the most effective shielding. Will depend on what kind of radiation the source is emitting. I won't go into detail, but enough to say that if there is available shielding, whether it be a lead gown, goggles, or a thyroid shield, always use it. It is significantly lighter now compared to way, way back before when it was significantly heavier. So I'll bore you first with radiation as well as its units because sometimes things like this, although rarely, they come out in the board exam. So, when we talk about radiation as well as its units, when we talk about the radiation exposure, the absorbed dose, this is described in milligray. Yes, like Grey's Anatomy, as well as in 50 Shades of Grey. So it's described in milligray, which is a concentration of energy from radiation that an object, which is your body, will absorb. There is different types of radiation, but I won't go into detail. But each type of radiation is assigned a risk factor. We call this the radiation weighting factor. So the absorbed dose is multiplied with what kind of radiation you're exposed to and its radiation weighting factor. And this is where you have the equivalent dose, which unit is MSV or millisievert. So we are talking primarily about X-ray and CT scans when we're talking about radiation. So luckily for us, the radiation weighting factor for these modalities, X-ray and CT, is 1. So the absorbed dose, milligray, is equivalent to is equal or the same as the equivalent dose, which is in millisieverts. Now, some organs in the body are more sensitive to radiation. So even though technically they would receive the same amount of absorbed and or equivalent dose when we're talking about CT and X-ray, the effect on that particular body part is different. In order to address this, and also to make it more confusing when I was a resident, organs and tissues have been assigned tissue weighting factors. So when we use this factor and we multiply it to the equivalent dose, now we get the effective dose. Now, somebody way before us and me and way above my expertise as well as my pay grade decided that the unit for the effective dose should also be millisieverts. So we have the same unit for two different things. So the dose of radiation that the patient is exposed to will vary. Again, it will depend on how much of what particular body part is exposed. Remember, some organs are more sensitive to radiation. What type of exposure? X-ray has less exposure as compared to CT, and what type of equipment, whether we're dealing with a PET scan, CT, or an X-ray machine. Don't worry, the numbers will not come out in your exam. So when we talk about basics of radiation in the future, I'm sure there will be patients who will ask you that, doctor, I've had so many X-rays, I've had quite a few CT scans. Am I still safe, is it already dangerous on my part? So for me, I found that this is the easiest way or the most effective way when we want to talk to patients. In the setting of healthcare, yes, we have radiation, but it does not only exist in healthcare. We have what we call a natural background radiation, which is here. So remember, it is not only medical devices that will emit radiation, but a lot of other things do, such as the sun or the microwave machine, so on and so forth. So this is what we would call natural background radiation. So in order for our patients to understand, when you have one chest X-ray, the approximate effective radiation dose is zero point 0.1 millisieverts. But when you say that, they wouldn't understand in layman's terms, what does that mean? It means that zero point 0.1 millisieverts is the equivalent of 10 days for a regular person walking around exposed to natural background radiation. So when the patient is walking around for 10 days, that's the equivalent of one chest X-ray. A chest CT plain study for 7 millisieverts that has a natural background radiation of about 2 years, so on and so forth. So what are the things that we have to consider? Pregnancy is one of them. It is one of the most important considerations in whether we're going to proceed with a certain radiologic study. Now, most modern studies do not pose a serious risk to a developing fetus. There is a very small risk of causing serious illnesses or other complications. However, it is very, very small. This small risk is what we must always keep in mind. All institutions have a set guideline. Now, this will differ from one to another, one organization as well to another. The ACR, or the American College of Radiology, based on their guidelines, you do not need pregnancy screening for all X-ray examinations except for the abdomen. So what do we mean by pregnancy screening? In our country, we follow the safer side, which is the ECR, or the European Society. what we do is we would ask the patient when was their last menstrual period, the first day of their last menstrual period, and to ask whether or not they are considering or they are suspecting pregnancy. If they are, and then if the procedure is deemed to be very, very important, and then we would have them sign a waiver, and we would place an apron or an abdominal shield. So I'll show you what that looks like later. So those are the ways that we will mitigate how um, we would mitigate or to see how to make sure that our patients as much as possible are not pregnant. But we can perform procedures if they are known to be pregnant, given that the procedure or the result of the procedure is extremely important for the mother's health. So again, for the ACR, they do not do any pregnancy screening for all X-ray examinations except for the abdomen. They don't need it as well for CT scan of the brain. However, in the local setting, any procedure wherein there is radiation or ionizing radiation, we would do a pregnancy screening. So, for those who are pregnant, most of them would be in their last trimester of pregnancy, and they need to have an X-ray or whatever radiation emitting procedure. Then we would be using an abdominal shield. When we think about radiation protection, this would fall under shielding. So this is an example of the abdominal shield. Now, if you notice, why is the lead gown or the abdominal shield behind the patient or posterior to the patient? So I want you to remember this image when we talk about the actual X-ray or CT scan study. So not all imaging modalities emit ionizing radiation. X-ray and CT do, however, MRI and ultrasound do not. MRI it deals with magnets, so it would manipulate the spin of the hydrogen atoms. And for ultrasound, they would use sound waves. So the only ones that do emit radiation are X-rays as well as CT scan. So what are contrast media? Contrast media, the most common would be iodinated contrast media. There are other contrast media that are not iodine. For example, for MRI, we don't use iodine, we use gadolinium, one of them. And then way back when, we used to have barium. So all of these iodine, barium, gadolinium, these are the most common. It depends on what diagnostic modality you would be using them in. But what they all have in common is that they have high atomic numbers, except for gadolinium, because gadolinium for MR has a different mechanism in having enhancement. So let's talk first about CT and X-ray. So most commonly we would use iodine and barium. However, barium is not as common anymore because there has been a worldwide shortage of barium ever since the pandemic. So we've been switching now to purely iodine. So these have high atomic numbers that strongly absorb the X-rays. They are seen as white, hyperdense, or very, very dense on radiography. So you can see here for a barium enema, we can see the large bowel and the rectum. Here, this is a VCUG, a voiding cystourethrogram. So we put contrast through an FBC and we fill the urinary bladder. So if you're familiar with the image on your left, this is the very first X-ray image that was produced. And then this is the present day X-ray image. Then from X-ray, we can also do CT scan. So this is a bone reconstruction of the hand with CT scan. And then MRI. So this is a T1 image. That means that it's more of anatomy. I won't go into detail about the different sequences, but this is an MRI image of the hand. So you can see that there are different imaging modalities and they show different things. One is more for bones while the rest is more for muscles and soft tissue. So how do we describe what we see? When we talk about the modality X-ray and CT scan, then we're talking about opacities as well as densities. That's how we would describe it. It's hyperdense, hypodense, or isodense. For ultrasound, we're talking about sound echoes. Therefore, it is echogenicity. It's hyperechoic, isoechoic, anechoic. For MRI, we describe our findings as intensity. So let's start with the X ray or the conventional radiograph. Wilhelm Roentgen, if you've heard of his name, he was a professor of physics. He's German. He discovered X rays accidentally in 1895. So he was in his laboratory and he was testing and experimenting with cathode rays. So we see this in very, very old TVs, whether or not these cathode rays could pass through glass. So he had a cathode tube, it's made out of glass, and he covered it in heavy black paper. So he was surprised when he saw a greenish light escaping and would project into a nearby fluorescent screen. So through experimentation, he found out that this mysterious light could pass through most substances but would leave a shadow when it's a very solid object. Because he did not know where these rays were coming from, he labeled them as X, meaning unknown. So then, hence, we have the name X rays. He also quickly found out that these X rays could pass through human tissue as well, could render the bones and the tissue beneath visible. So he received the first Nobel Prize in Physics in 1901. So the image again to your left is the first ever X-ray taken of a human. This was taken in December 22, 1895, specifically of the left hand. It's complete with the wedding band and the engagement rings of a ma'am, Anna Bertha Roentgen, the wife of the man who accidentally discovered a form of radiation that would change the face of medicine. So his first experiment, of course, just had to be his wife. So this is the very first known X-ray taken of a human being. This one is in December 22, 1895. Okay. So when we talk about the basic densities, we would arrange them from least to most dense. This is based on how much they would absorb the X-rays. Air is the darkest, so it would appear black because it would not absorb anything and would let all of the X-rays pass through. Fat has a lighter shade of gray than air. So that one would be air pointed at. It appears very dark because that's the air that we see within the alveolar sacs of the lung. Then it appears gray. So it's a little bit grayer compared to air, but not as white as soft tissue or fluid. So both soft tissue and fluid appear the same on X-ray. How do we remember this? We looked at this particular structure, which is the heart, and it is impossible to differentiate specifically where the heart muscle or the myocardium is and where the blood is. So remember, soft tissue and fluid appear the same on X-ray. Calcium or bone is also brighter. However, the brightest would be metal. So the one that's pointed at is a left-sided pacemaker. Although not shown in this image, contrast media does appear as almost as bright as the metal that we see in the pacemaker. So images produced through the use of ionizing radiation are called conventional radiographs. Sometimes you hear the term plain films or X-ray. A major advantage of this is that images are relatively inexpensive to produce. The machines are not as expensive as compared to CT. It can be obtained almost anywhere as long as there is adequate protection, of course. It can be portable or mobile machines, and they are the most widely obtained imaging study. Used for our very famous, you will be very familiar with this in internship, it's the famous chest X-ray. However, you can also have abdomen as well as the MSK or the skeletal system. However, there are disadvantages. This include a limited range of densities. We can only see air fat, soft tissue, bone, and metallic structures. We can also see contrast material. It is also radiation emitting, so we do have that radiation risk. So again, here is our very famous and very popular chest X-ray. So what else can we get other than your regular run-of-the-mill chest X-ray with the help of contrast media? So an intravenous pyelogram, it's also called an intravenous urography. This is referred to as, or sometimes called an excretory urography. You don't have to memorize all those. This is a radiographic study of the renal parenchyma. pelvicoileal system, ureters, and the urinary bladder. However, this exam has been largely replaced by CT urography. So this is the scout film. That means it's the plain study. It's just a regular x-ray. And then we would give the contrast and in a fixed amount of time. So we would take it at 15 minutes after contrast is given. This is through IV. Then 15 minutes after injection of contrast, and when the patient has full bladder, then we would let them urinate, and then we would take the images again. So the image on your left is a plain study. The image on your right is a nephrogram taken at 5 minutes. So you can already see parts of the kidney here lighting up, or it's starting to have enhancement. We weren't able to see that before. And then again, we can see more of the kidney on both sides. And we can also see that the contrast has now started to go to the pelvicoileal system as well as the ureters. We can even see a little bit of filling here now in the urinary bladder. Here we have our full bladder. We have presence of contrast within the pelvicoileal system. The kidney nephrogram has already started to fade away because then the contrast is being excreted. And here we have the ureters on both sides. So this is the full bladder. Okay, so we can see the difference here. So the image to your left, this is a plain study. So we don't see, and no contrast was given. However, we do see a hyper dense focus here. So this is a calcification. This patient is known to have a nephrolithiasis in the right kidney. And then here, this is a patient who underwent the same particular procedure. And then you do notice, if I'm not sure if you noticed, but in the previous study, the cortex would be rounded up here. However, you have a connection here. So this is a patient with a horseshoe kidney. That is where the inferior poles of both kidneys are fused together like a horseshoe. Other things that we can do, we can also use it in real-time visualization. So imagine a video camera. So it's a constant stream of x-rays, and then you can piece it all together, and then we call it a cine study, a cinematography study. So this is, again, constant stream of x-rays. Radiation is a little bit higher. So here we can actually see movement of the body parts through x-rays. One of them, it used to be called a barium, one of the barium studies, but however now, because of the shortage of barium, we use iodinated contrast material. So we call it an esophagogram. So what is this? This is a dedicated test of the pharynx, esophagus, and the proximal stomach. This may be performed as a single or a double contrast study. When we say single study, that means it's only the positive contrast. When we say it's a double contrast, that means that after the patient has swallowed a relatively thick concoction, and then we would take another image again so as we can see the outline more properly. This study is often quote unquote modified in order to suit the history and symptoms of each individual patient, but it is most useful to evaluate the entire pathway from the lips going towards the gastric fundus. So in some institutions where I work, we do this quite often because they want to see the esophageal motility, whether or not there is a stricture, especially for patients who have ingested chemical compounds. So they want to see whether or not there is a stricture. If ever a procedure was done, let's say patient was known to have an esophageal carcinoma, and then they would resect that portion and they would have end-to-end anastomosis. When they do that anastomosis, they want to see whether or not it's intact or whether there is leaking or it's not an intact anastomosis. So that's what they would want to see. We could see that through an esophagogram. So these are the normal appearances of the esophagus. Also note that there are normal extrinsic impressions of both the cervical as well as the thoracic esophagus. So this is from the cervical spine. You can see it in the lateral view, that here is the spine, but you have that indentation here. So this one is normal, it's not abnormal. Okay, then this is the esophagus, this is the stomach, so this is your gastroesophageal junction. So this is normal. All right. Then barium enema, or now we just call it an enema study. You could have a single or a double contrast, but almost always we do a double contrast. So we would first give the contrast material. We would fill the colon up to the ileocecal junction. So that would be somewhere, oh, this is the other way around. Okay, it would be somewhere here. Yes. So when we see that it has already reached that portion, if the patient is normal, and then that's when we would stop. We would drain everything. So I hope everyone has had their lunch, and it was a long time ago. So you can imagine what kind of unspeakable things that we've seen as it comes. It would backflow, going back towards the bag where we would administer it from. So everything would backflow. And then we would change from the contrast material, we would change it to a pump. So the pump is similar to the bulb that we use in the sphygmomanometer. So we would pump air and then we would give air, so it would look something like this. So that would be a double contrast. So why is that important? So this part is where there is still presence of contrast. All you can see is just the outline, but you cannot see the inner margin of the bowel because it's all filled with contrast. As compared to here, if ever there was a polyp or there was a mass or something like that, and then you would see its outline this way. So this patient was normal. It's a very, very nice study, beautiful study. Okay, this is avoiding cystourethrogram or VCUG. Sometimes it's called a micturating because people, the medical term to urinate is to micturate. MCU or a micturate urethropography. This is a fluoroscopic study of the lower urinary tract. How do we do this? We would introduce contrast into the urinary bladder via a catheter. So the purpose of this examination is to assess the bladder, the urethra, the postoperative anatomy if your patient did have surgery, and as well as during micturition, so while your patient is urinating, to determine whether or not there is presence or absence of VUR or vesicoureteric reflux. So ideally, there is no contrast that is supposed to reflux back up to the ureters and towards the kidneys because it's supposed to be intact. You're not supposed to have reflux. However, if you do have reflux, it would appear, this is very severe. It would appear something like this. So the contrast is supposed to remain as is, like in this patient. However, in this patient, you can see that there is reflux of contrast into both ureters and pelvocalicial system, which is very, very enlarged and dilated. So this is the most severe form of vesicoureteric reflux. Usually, we would have requests for this for pediatric patients, especially male patients who have recurrent urinary tract infection. But for the women, also, we have a study called a hysterosalpingogram. This is a fluoroscopic examination of the uterus as well as the fallopian tubes. This is most commonly used in the investigation for infertility or recurrent spontaneous abortions. So in a normal HSG, we would see first you would have filling of the uterine cavity, and then it would go into the fallopian tubes, and normally you could see intraperitoneal spill of contrast within the abdomen. So here, as it's filling, and then you can see that these are the fallopian tubes, and then you can see the contrast just spilling out. So this would be normal. Okay. This would be, yes, so those are normal. Okay, so for CT, this was first performed successfully way back when in the 1970s in the UK at the Central Research Laboratory of EMI. So the very first clinical CT scan of a patient took place in 1971 in London. So this patient was a lady with a suspected frontal lobe tumor, was scanned with a prototype scanner developed by Godfrey people in the EMI. And then they were able to take this particular image. Now, just to take this image took 5 minutes for each particular slice. Now, with how fast our CT scans are, you don't even have to blink. The CT scan is already done, especially those that are very, very fast. Okay, one where I work, the CT scan can do a particular slice in less than zero point 0.3 seconds. So because of this, here's the mass that they were talking about. So that's the hypodensity that we see in the in the right frontal lobe. So again, the Nobel Peace Prize was awarded for all of these people who discovered the CT scan. Okay. So this is what was the first image, and then this one was an image taken of one of our patients a couple of months ago. Okay. So when we talk about densities and opacities, um, we would describe it as hyperdense, isodense, hypodense. So what would we refer it to? So we know when you say hypodense, it's darker. When you say hyperdense, it's brighter. When it's isodense, it's of the same. But in comparison to what? So in comparison to the normal brain tissue. Remember this normal brain tissue. So particularly the cortex or the gray matter. So when we say it is hyperdense, it is brighter than the gray matter. If it's hypodense, it's darker than the gray matter, so on and so forth. How do we describe this? So Godfrey Hounsfield, the inventor of CT, they gave this unit for to describe density as Hounsfield units. Okay, so when we talk about that, when we talk about that, the most dense would be bone, which would range around 400 to 600. Air would be the least dense, which is can go all the way up to the negatives. Also remember that fat is also one of the lesser dense, although not as least dense as compared to air. So when we talk about density in comparison to what, since we're talking about Hounsfield units. So let's backtrack a bit. When we talk about this, so let's cut off this piece. So this is air. This is very, very hypodense. Bone is bright. So it is hyperdense in relation to the gray matter. This is the brain parenchyma. And this is CSF, which is also hypodense. Okay. So when we talk about the different positions of the CT scan, when we see something like this, we call this the axial. Here it's transversal. I know I couldn't, honestly, I was too lazy to change it manually to axial. But you can call this transverse, but universally it's known as the axial slice. Coronal is when you divide into anterior and posterior. Sagittal when you divide left to right. Okay. So with the use of a gantry, that's where the patient would lie down. Then you would have rotating X-ray beams and multiple detectors. That's where the X-ray beam would be projected on. Okay, so these would turn over and over again. Then we would be able to get a large number of images, and then we could have 3D or we could have MPR or actual coronal and sagittal images when we would reformat it. So this CT scan is connected to a computer, which would then process lots and lots and lots of data in order to produce beautiful images of diagnostic quality. So CT scans can also be windowed in a way that will optimize the visibility of different types of pathology after they are obtained. So when we talk about windows, what does that mean? We'll discuss a little bit more on that later. So remember that there is a benefit for CT scan called post-processing. So in digital imaging, it is already quite advanced. So post-processing would allow for the manipulation of the raw data to best demonstrate a particular abnormality. So when we talked about windowing, remember that the monitors have the ability to display 256 shades of gray, but the human eye can only resolve 30 to 90 shades at a time. So what does that mean? So imagine if you line up all of your 256 shades of gray from left to right, but we can only see 30 to 90 shades at a time. So then we would be missing out on 150 to 200 plus of the pathologies because we can only see 30 to 90 at a time. So windowing will allow the reader to focus on certain tissues, so it would shift where along that particular gradient of 256 shades of gray, what you would like to focus on. So this is an example. Here, this is all the same image, the same patient, the same slice. The only thing that we changed was the windowing. So when we did a soft tissue window, this is a patient who underwent trauma. So we can see that you have the aorta, and then this is part of the greater vessel. So this is your pulmonary trunk. right and left pulmonary arteries. However, if you notice, the bones and the lungs are not as clear. So exactly the same thing. If you notice, we changed the windowings. You can see the change in the W. You can't really see the change in L, but this is what we mention when we talk about change in windowing. So here we focus primarily on the bones. So now our 30 to 90 shades are more specifically geared towards the bones. We can see whether or not there is presence of fracture. If you notice here and here, the the quality of the bones look different. Then here we're looking more towards the airway. So no, we don't see any pneumothorax or things like that within the lung. So overreaching. So overall, we're when we talk about angiography. So this is also something else that we can do with CT is that you would have optimal enhancement of the arteries with little to no venous component, so purely arteries only. The technical aspect of the examination will vary from one institution to another. So, a normal CTA of the carotid and vertebrobasilar arteries, that's the image that you see. And then post processing would be done, and then we're able to remove everything else that we can see only the arteries. We can also do bone reconstruction, such as this patient, wherein there is a very severe fracture in the left femur. And then here there is a large lytic lesion. This patient unfortunately was due to metastasis in the occipital bone. So ultrasound, this is the very first image detailing the ultrasound. This was back in 1794, so it's even earlier than X-ray, as well as obviously as well as CT. So the concept behind it was that an Italian physicist, Lazzaro Spallanzani, he analyzed the basic mechanism of navigation with flying bats in the dark. So he would observe the bats and then he would say that okay, they have to be doing something because they're not hitting into each other and hitting into other things. Then let's jump to 1948. George Ludwig, he's an internist in the Naval Medical Research Institute. That's where he started to develop the ultrasound. So if you look at this, I cannot point out exactly what is in the image. So this one was supposed to be a fetal head, but I don't see how it is a fetal head. But thank goodness ultrasound has come very far. So now we can see that this is an ultrasound of a fetus, and here is the head. That's his nose, that's his or her nose, and the lips and the little fingers. And this is the body. And we can go now a step further into 4D of a fetus, such as this. And you can see the baby smiling. Okay. So traditionally, this is we would get ultrasound images by an effect calling the piezoelectric effect. However, this one was in the past. Now everything is mostly digital. Okay, so what you would see is you would have ultrasound waves go through, then you would have reflection, absorption, or transmission. So whether or not it is completely reflected, as in bone, and then all of the signal would go back, and then nothing can go through. Therefore, it would have a particular image. This would appear hyperechoic. Liver, you have a combination of two. Some will be absorbed by the liver and will go through. Some of the ultrasound waves are able to go through. However, some will bounce back and will be reflected back to the transducer. As compared to the cyst, there is a lot that will go through, but very minimal will reflect back into the transducer. So through a combination of these and then the different organs as well as the different pathologies, we can see how it can appear different in ultrasound. So ultrasound, when we talk about ultrasound, we talk about echogenicity. So this reflects more of the echoes. So it's more of the echoes. Hypoechoic is it would appear darker than the surrounding. Anechoic means that it transmits all echoes, so it's completely black. So this is a study of choice for the female pelvis, gravid patients, pediatric patients. It can differentiate solid versus cystic, and it is also a non-invasive vascular imaging. Okay, so we have echogenicity. Anechoic appears very, very dark. Hypoechoic is also dark, but not as dark as anechoic. Isoechoic means that it is the same as everything else. Hyperechoic is brighter. So this is how it looks like. Anechoic, everything is dark. Isoechoic, you can barely see the lesion. Hypoechoic is darker, but not as dark as anechoic. And echogenic or hyperechoic means that it is bright. So we'll just breeze through this really quickly. This is the transverse plane. I'll detail this a little bit more when we talk about the abdomen. Okay. So this is your when we're holding the transducer. So this one I would like to show you hopefully in person the next time that we do meet in person. So I'll discuss this later because usually I do this on site. Okay, so ultrasound, it uses high frequency sound waves that would characterize tissue. So this is the kidney and this is the liver. All right. However, so why is this good? It is widely available. It is not as expensive in terms of machine as compared to an MR or a CT. It's a study of choice for the female pelvis, pediatric patients, and the gravid patients. However, it is operator dependent. So there are instances wherein it depends as to the expertise or the how advanced or how experienced your operator is. And then in patients who are very gassy, it is very poor for this. So if you have a patient who has a lot of gas within the bowel, when you do the ultrasound you can't see anything. Okay. You can also turn on a particular mode wherein you can see the vascularity. So that would be the vascularity. We see it in blue and red. Blue does not necessarily mean venous, red does not necessarily mean arterial. It just means that blue is either going towards or away from the transducer. So this can be set within the machine. For MRI, Tesla, his name is very familiar now. Nikola Tesla first described the rotating magnetic field in 1882, but it was only in 1937 when a physicist, Isidor Rabi, from Columbia University, developed a method for measuring the movements of atomic nuclei. So he again won the Nobel Prize for Physics. And then meanwhile, while that was going on in the UK, there was another physicist named Peter Mansfield who was tackling the question was how to get particular images using this new technology. So this man is his grad student by the name of and no, sorry, it's not this man. I take it back. This image was a finger of his grad student Andrew Maudsley. So it took 15 to 23 minutes per section, marking the first time that a human body part had been successfully scanned with the technology during the time. So this image was done in this particular image was done within 23 minutes. Okay, but the first body MRI, now by this man here, was taken where it was an MRI of the chest. So it was his assistant, lo yan yung mga assistant and postgrad students, no? So they are the ones who were the sample patients. And then his chest was obtained in 1977. This particular image required, guess how long? 5 hours to produce. So it took them 5 hours to produce this particular image. So these images are very different from what images we can produce today. So this is the latest image that we can get of the thorax at about this level. So MRI, when we describe it, we call it intensity. It's widely used for neuro, soft tissue, especially the muscle, the tendons, and the ligaments, as well as advanced imaging such as tractography and CSF flow studies. I'll just touch this a little bit when we talk about when we go on to talk about the neuro. So when we talk about MRI, we talk about the potential energy, and all of this would be manipulated by a magnet. No radiation is emitted in these studies. However, MRI safety still exists. This is different from the radiation safety because when we talk about MR scanners, there is an extremely strong magnetic field. Okay, so basically, in a nutshell, we'll go through this really, really quickly. Our body is made up of a lot of hydrogen atoms. So they would use the magnet, and then all of these atoms would be forced to spin at a particular angle or at a particular axis. Then they would release that magnet, and then all of the hydrogen atoms will go back to its original spin or its original axis. By doing that, it would release certain signal, and then that signal is captured by the MR machine, and we're able to get the images. That is like the easiest way for me to explain how an MRI image is taken. So I won't go too much into this, but just note that there are different things that we can get other than pure MR images. We can get an MRCP. This is similar to, you've heard of an ERCP, except this is the MRI equivalent. These are things that can be done when there are brain masses. So we would get a particular sample. So we would ROI, or region of interest, that, and then we would see what kind of information we can get from that. So I'll touch that a little bit later. This is very beautiful tractography. So we're talking about white matter and gray matter. Here we can track the white matter. And then functional studies. So part will light up when you ask your patient to perform certain tasks. Okay. So what have we covered for the past few minutes? We've covered the basics of radiation, radiation safety, as well as the different imaging modalities. So before, I used to discuss all of this here, but I feel that it might be a little bit better if we discuss this when we go into the different imaging modalities or for the different organ systems when it comes to this. Okay, next week, can we meet again, please, on a Tuesday? Because I will also be out of town next week. So if it's all right, we'll meet the same time here on Tuesday next week, if that's all right. We will
Yes,
be
Doc.
dealing with the chest. So this is my son's, again, his thing. He's grade 9 now, so he's horrified when I tell him that I still show this to you guys. So we'll be dealing with the lungs. I don't know why there's an apostrophe. So it should be no apostrophe. But let us forgive his grade 3 self back then. Okay, does anybody have any questions? All right, so if I believe silence means there are no questions. So okay, hold on. I'm going to send right now. Where's this? All right, where's our chat? Hold on. Cannot find the chat. Okay, here's a chat. Okay, so I have a short activity for you. Nobody panic. It's not that difficult. So I'll have okay, it's a short activity for those. So I'll leave this on until 5. Let's do, since you're all here, I'll close this at 5:05. Okay? Okay, everybody chill. It's really simple. Hold on. Okay, there we go. So if someone's able to go in and answer, please do. This one will close at 5:05. If you did take notes, go ahead. It's a very, if you were listening at all to me while I was yapping on for the past hour or so, then you should be able to get it. So this one will be ending soon. I think I'll send this to you na lang. All right, anyway, I'll send this on Viber to you, my dear, so that you have the next like 10 minutes or so. I was able to keep this in within 1 hour. Very good. Let's hope to keep it within 1 hour as much as possible. All right, so if no questions, our Google Meet is going to end soon because I realize I don't have the premium. Okay, you guys probably do because it's .edu on your end. So, okay, so if no questions, thank you everybody. If you do have questions, you have my email me lang. If you have any questions, see if how I can help you make radiology a little bit more palatable to everyone. Okay, so I believe everyone is able to answer because nobody is giving me violent reactions. All right, so thank you everybody. I will see you all again next Tuesday, same time. I'll send the link, and I'll also send you the PDF of this after I've closed the Google Form thingy. Okay.
Doc, excuse me, Doc.
Yes, dear.
Dili ta mag-class karong Thursday, Doc, no?
No class.
Yes, thank you, Doc.
Okay, so everybody enjoy yourselves this Thursday. All right, thank you. I'll see you all next week. Babush.
Thank you, Doc.